finally, I see in the back of the room Dave Dudak, and there's another Jim Cesario. These are two of our vendors that help support the dinner tonight. I'd just like to thank them very much. So, how many of you know about SCAD? Quite a few. That's pretty good, actually. This is sort of a regular talk that we give to our fellows. And
everybody hear what you want me to mic in? We have a mic.
You guys okay in the back? You want the mic?
Sorry, my bad. I'm such a big mouth, I forget about the mic.
This is a big mic.
Wow.
Well, we'll continue while we're waiting to get that working. So this is not a terribly common problem. This talk is one that we use for our fellows in general and interventional cardiology as part of our curriculum that we teach year in and year out. We usually do this talk if we're there 3 years, once or twice. Is that better? Yeah. Too loud? Just right? All right. So with no further ado, we'll try to move along and see if we could start with a case presentation. I know we have some patients here who've been a part of this, but this is not an atypical scenario. So 45-year-old and female, so those two things right away. Younger patient and a woman shows up in the clinic, and 6 months prior to the clinic, she'd gone to a hospital where she had a day of chest pain. And, you know, at 45, our radar isn't all that high for a woman with chest pain, although we still think about it. At that time, she had absolutely no other medical history, healthy woman, taking no medications. She didn't smoke, had an occasional drink or two. Do you guys have any drinks tonight? One or two, I hope. So they ran, the EKG shows sort of non-specific. There really isn't anything there that would catch our eye to tell us something acute. Now, these presentations can clearly vary. However, troponin was elevated at 3.5, so normal is usually less than 0.04 in the Loyola system. So 3.5 is a real number that catches our attention. And she's diagnosed with a non-ST elevation myocardial infarction taken to the cardiac cath lab. It's important to know that she actually had a pretty good history taken by the fellow who saw this patient. She didn't really have any risk factors at all. She had no hypertension, no diabetes, her cholesterol was awesome. She didn't have it in her family, and she was not a smoker. So, and in addition, a very active lifestyle. Just your model patient, the kind of patient that we all want to see in our office because they're pretty easy to take care of. Nevertheless, she has a spontaneous coronary dissection. So how is that defined? And it's really a spontaneous separation of the coronary artery wall that is not iatrogenic, meaning we didn't do it. It wasn't during a cath or during some kind of an interventional radiology procedure or some surgical procedure. The contemporary usage of this term is really reserved to patients who do not have any other signs of atherosclerosis, so that it's really a clean coronary system, and it just happens. First described case was way back in the 30s, 1931, when a 42-year-old female died suddenly after basically puking, and resulted in dissection of an atheromatous artery. So in this day and age, that wouldn't qualify as a spontaneous coronary dissection, but that was when we first recognized that coronary dissection can happen. And it really is hard to know that far back whether there was really atherosclerosis or did we just sort of assume because that's what we assumed everybody has. There has been an improvement. There's been a significant improvement in our ability to look at coronary dissection. So OCT and intravascular ultrasound are both tremendous tools in the cath lab. And I'm going to say right now that we usually end up, because of the troponin elevation chest pain in the cath lab, And these tools help us to really nail down, is this truly a spontaneous dissection, or is this just a garden variety atherosclerotic process? But the other tool that we use once we know somebody has a SCAD, if they have a recurrent chest pain, is CT angiography. It's gotten so much better, and it allows us to evaluate these patients with a little bit less invasive approach. And there are reasons for that that I'll go through in a minute. This is not common by any means. I think there's about 1,500 cases reported. We're starting to get better at recognizing this, and I think with troponin being so sensitive that we probably pick up more now than we did 15 or 20 years ago. And as you can see, half the cases have been diagnosed in the last 5 years, which is a tribute to the improved technology and improved lab testing that we have. We don't really know the incidence or the prevalence. Many suspect that it's underestimated because, again, it's a younger woman. We kind of say, well, you know, they have any chest pain but cardiac, right? I think this report that there's a prevalence of 1.7 to 4% seems a little high to me. I quit counting at 35,000 angiograms. I've done 35,000 of them. And I can tell you that 4% of them have not been spontaneous dissections. I can count. I probably see, I think I do about 1,000 procedures a year. I probably see 2 or 3 a year, maybe 4. So it is not all that common. Autopsy cases, they found about 0.5% of those patients who died suddenly, 0.5%. I think that number is probably a little closer, maybe a little higher than that, but not much. Again, 90% women, so this is a Me Too movement. I mean, it is the women, right? Almost invariably when you hear SCAD, you think, and oftentimes younger women. 35%, probably less than 50, and it may be a little bit more than that in my experience. So that's kind of the epidemiology of SCAD. So how does this work? So we know that an artery has 3 layers. If we look down the artery like we're looking down the barrel of a gun, there are 3 layers of a vessel wall, and there's 2 hypotheses that have been proposed. One is we think about sort of non-STEMI and acute MI in women being a little different than men, particularly in the younger women, where instead of ulceration of the intima, the inner lining of the vessel wall, we think more of erosion. It's a little bit different of a physiology. So it's not a big nick and crack in the vessel wall. It's just kind of like you took a little sandpaper and rubbed it. It's just irritated and angry and aggravated. So one theory is that these spontaneous dissections happen on top of an erosion on the intima or the inner wall of a coronary artery. And the other is that it happens from inside out. So if you think about intima, media, and adventitia from in to out of the vessel wall, that actually in the media, the middle wall of the vessel artery, you have vasobacillum, which are little tiny blood vessels that supply that layer, that muscular layer. And some people think that maybe those little blood vessels rupture, cause a collection of blood or hematoma, and that hematoma tracks and kind of ruptures that or penetrates that intima, that inner lining of the vessel wall from middle working its way in to where the blood is. So those are the 2 hypotheses. As far as I know, nobody's actually been able to clarify which one of these is correct, and maybe one or both or a combination. One or the other or a combination of the 2. Without a doubt, just like a dissection anywhere else in the body, once that layer is opened up, blood is under the pressure, under our systemic blood pressure, it enters into that middle wall and starts to collect a hematoma. So we have a mural hematoma, if you will, a vessel wall hematoma. And as that hematoma gets bigger, we start compromising the actual lumen of the artery itself. And it just depends on how big the hematoma gets, how much the vessel, the actual blood carrying capacity of that vessel is compromised, and as a consequence, how much injury that patient will sustain. Once we have a defect in that lining, the blood, that hematoma can propagate both backwards and forwards, so both antegrade and retrograde. And these things can get pretty long. I remember a lady that I took care of about 6 years ago who, this is another kind of not unusual thing, it's right after childbirth. So this was a 32-year-old woman. And she started having chest pain up in the delivery room. They did an EKG, it was clearly abnormal. So up in the delivery room, she was a bit actually wasn't delivery room, postpartum area. Her blood pressure was like 90, and by the time she came down to our cath lab, her blood pressure was about 65. She wasn't feeling very well. And so she had a dissection, and that thing had basically, was in her left system, so it had gone LAD, circumflex, and left main, everything, just shredded. And I remember saying, help, bring me a surgeon. And surgeon came down and said, oh, you're on your own, we're busy, we can't help this. So we ended up, that poor woman ended up with about 9 sets, literally just everything to tack it up. She still sends me a Christmas card every year. She moved to Atlanta, she's doing very well. There's nowhere left for her to dissect, and so far, knocking on wood, no stents re-narrowed, so she's doing okay, and her baby's now, I think, 7.5 years old. So it's kind of a happy story. No, she just the stress of delivery, exactly. And but just a fantastic woman, and her and my nurse bonded quite a bit. She kind of likes me a little bit too, I guess. But anyway, she's doing fantastic. And so these presentations can go from relatively subtle to very dramatic. It just depends on how much that artery decides to tear. These are pictures of the vessel walls. So this is a normal, healthy vessel up here. So the intima has a very thin layer, literally like a cell or two. It's really thin. The media is that thicker, muscular layer, and that's what allows the artery to kind of squeeze and relax and react to whatever the demands are of the vessel. And then finally the adventitia, which is just sort of out here a little bit fatty. This is sort of a depiction of what happens when you have this so-called rupture. And you can see how you have a hole here, and now the blood, the circulating blood, has access to the media, that inner layer, and it can just kind of expand. Which explains the behavior of some of these patients. Why do people get this? Well, some probably have some sort of predisposing arteriopathy or angiopathy. So FMD is considered to be one of those. Fibromuscular dysplasia was seen in about half the SCAD patients at Mayo Clinic. And Mayo Clinic has a big program up there where if you are identified as a SCAD patient, I usually send them up there. These patients are entered into a registry and then followed, mostly electronically, through just regular email type communication. But it allows us to learn and develop a body of data about this group of patients. So if you ever meet someone who's had SCAD in their medical history, it's worthwhile so that we can learn more about the natural history of this and try to learn more about maybe what interventions are or are not helpful to the group of patients, because we don't have all the answers. We really don't right now. There's still a lot of mystery. A group saw, and their group found that a lot of these people do have some stressors, emotional as well as physical. So surprisingly, about 40% of those had identifiable emotional stress prior to their SCAD event. And I have one teacher whose stress was just doing her grading, and she knew she was going to have some very irate parents, and it really triggered it for her. That was the only identifiable stressor for her. Others could be physical stress. So, as they mentioned, I wear 2 hats. I also wear a hat out at St. Joe's. The Chicago Marathon's coming, right? That's going to generate $360 million for the city. Believe it or not, I just heard that on the radio. But that's a lot of numbers. And every year, has had massive humanity runs by the hospital. We will get 1 or 2 dissections. Sometimes it's coronary, sometimes it's carotid. We've had renal, we've had every dissection imaginable. And every year we know we're getting 1 because it's close. St. Joseph's right by Loyola, so physical stress can do it. Now, I personally believe that part of the deal with the marathon isn't just that physical stress, but it's the relative lack of hydration. Now, that's hypothesis. I don't know that for sure. But it seems like those folks that we see after this just grueling long run are those who weren't able to maintain their hydration. You know, you can make your best pie, see somebody drinking. Prevention's always better. So I do believe that good hydration, if you're working out, is critical. And you all know how to know if you're hydrated correctly? Your pee should be clear. Yep, your pee should be clear. We tell all the kids that when I used to coach. So, as we said, people can present with all different cardiac MI presentations. They can be small MI, they can be a cardiogenic shock, as the woman that we saw after her delivery. They can have ventricular arrhythmias or other arrhythmias. And sometimes it's just a subtle chest pain. So there is the whole spectrum of presentation in these patients. Almost everybody has chest pain or chest discomfort. Cardiologists always say chest pain, pressure, burning, whatever descriptor. And you need to sort of pin them down a little bit and make sure it does sound cardiac no matter who you're taking the history from. Many of them are unstable because as that hematoma expands, it can get bigger, get smaller, track this way, then get bigger again. So they do have a bit of an unstable presentation, and those are ones that we usually pick up because their enzymes are positive, they ask for help, and it's kind of like one of the vital signs: blood pressure, heart rate, respiratory rate, troponin, right? You know, everybody gets that nowadays. So we usually see them. Most of the time, if they're not big MIs, they're going to have preserved heart function, decent ventricular function, but not always. So, how do we diagnose? Angiography is going to be the de facto first test in most of these people. CT angiography has become much, much better in the last 5 years. The problem with CT angiography is it's a dye load, and 99% of our patients aren't going to have SCAD, they're going to have atherosclerosis. So if we're going to give them the dye, we might as well give them the dye and be able to follow with a correction, which is in this day and age not infrequently a stent. So for the most part, coronary angiography is by far and away the first step. Now, the one thing I would say about CT angiography is you need to have dedicated CT angiographers. They have to be trained in it. It can't be kind of one of these, well, I'm a radiologist and I'd like to do a little CT angiography. You have to have people who commit to it. It's a really tough exam to do correctly. I don't do it, but I do know that there are differences when I see the exams where they took the time to make sure the heart rate's slow, to make sure that the CT scanner is gated. There's a whole lot that goes into a good CT. So you want to get them at places that have a big, vast experience and know how to do it and what they're seeing. Typical angiography findings are just like any other dissection. Extraluminal staining, which is kind of an angiography term. Multiple radiolucent images, so you'll see kind of gaps or skips in the artery. The spiral dissection, which we can all kind of tell, and then filling defects. Many of these are non-specific, but in the right pattern, we can then make the diagnosis of dissection. This is a little bit of esoterica, if you will. This is talking about angiographic findings, and for some reason, a lot of these patients have more tortuous vessels. They just are the long, winding road, and they're very tortuous. So we can score tortuosity. None of you care about that, probably. I'm not sure I care about it, at least how to score it. But we do see that these patients are more likely to be tortuous. And when we see repeat dissection, it's more likely to be in the curved area of the vessel where it's a tight bend. Now, why is that? Those shear forces are accelerating. You have more shear forces on these bends, and that's probably why that we see it more commonly in the tortuous segments than in the straighter segment. So, we have angiographic classifications. This is kind of for people that are going to do angiography. But this is a really nice angiogram where I think you can kind of see it. So the coronary artery is just like a tree, and in this case, it's an upside-down tree. So the trunk of the tree is here, and the leaves are down here. And the tree of a coronary artery should just get smaller as it goes out towards the leaves, right? The trunk should be bigger than the next set of branches and the next set of branches. And if you look here, this is clearly smaller here than down here. And this is what's called extraluminal staining. So that's where the blood got in through that crack, or the dye in this case, gets in through that crack and staining in the media of the artery. So this is a really, really, I think, kind of classic example of a spontaneous dissection. And the other thing that's important is the rest of the arteries are smooth and clear. There's nothing else here. It's longer than we would expect. You have the extraluminal staining. And that just kind of, that should send a signal that maybe coronary dissection. I think we have a couple other examples that aren't quite as good. There's a type 2 that's diffuse and of varying severity. This is a subtler, more difficult diagnosis to make. And I think they throw a picture up here that is sort of, again, shows the point. So you see this vessel is this big when it starts, and then all of a sudden it becomes very tiny. Now that could be, just a ruptured plaque, but it just kind of stays small all the way down here. That vessel should be much plumper, much thicker. So that's another example on an angiogram of what a spontaneous dissection looks like. The rest of that's kind of, this one's really subtle. I don't even think I can see that one. And then finally, this is sort of an interesting visual for you guys. So here's where the dissection is, where the little snowflake is. This is called OCT. And OCT is just the same thing like ophthalmologists use in the eyes. We're just bouncing ultrasound inside the vessel and making color. So you can see the intima here in the yellow. It's really easy to see that, right? I mean, I think you guys can see that. And now you see this crescent out here. That's where the blood has penetrated into the vessel, into the medium. So the vessel is from here to here, should be, but now it's all scrunched down because of that blood tracking into the middle layer. There's a couple of really good examples on here. So both OCT and IVUS can be used. IVUS is intravascular ultrasound, where we have a little ultrasound crystal that goes inside the vessel. OCT is what we just described. Most people would say that OCT has better spatial resolution, but IVUS has better penetration, so you have a little bit deeper of a look with the IVUS. OCT is not commonly used in most labs. Most cath labs will have IVUS. So IVUS is going to be more commonly used. The OCT is better at finding these little rivets and dents in the vessel wall, but an experienced IVUS person will see it as well if they're careful. And I think these pictures show it really, really clearly. So this is the lumen of the blood vessel, right? The blood's going through there. That's the catheter there. Look how clear you can see the catheter. Right there is the little dent, the little rent, the defect in the vessel wall, where blood's coming in, and now it's collecting out here in the median. So you can see it very, very clearly there. That big crescent is just blood that tracked from where it's supposed to be to where it's not supposed to be. This is IVUS, and you can see that the OCT is a clear picture, without a doubt. But here you just see this big crescent, which is, in this case, blood that's collected again in the median. So two pictures of the same segment, same vessel, two different ways to look. You can see why OCT is a little bit more clear. But again, that's not commonly used in most cath labs. So what are the advantages of these things? Well, we can make a definitive diagnosis of SCAD if we use OCT. We can, I don't really believe in this, but for maybe some operators, they say, well, we know that we're in the true lumen as opposed to the false lumen. So if you think about it, this is a snowman where you have true lumen and then the false lumen. So if our wire, as we're trying to access this thing, goes through that little rent, gets in the false lumen, we can go all the way down and make a mess out of things. So OCT theoretically would help to make sure you're where you're supposed to be, generally by watching how the wire behaves. You can tell when you are or are not in true lumen. It does help to make sure the stent's properly sized and that we don't leave any dissected segment uncovered with the stent. Disadvantages is it's invasive and it is quite costly. Again, it's not available in all labs. Any of these tools have the potential of actually extending that dissection cleft. These vessels are extraordinarily fragile, and you have to be extremely, extremely careful and patient when treating these folks. You can't go quick. You got to be careful. The other thing about OCT is people don't realize this, or many people, but we use contrast to, like dye, to help outline the vessel wall. That gives you the right chemical to bounce the ultrasound off. The problem with that is you're using a lot more dye, and people who have renal embarrassment or kidney problems, you could potentially give them more dye and increase their complication rate with regard to kidneys. So how do we take care of them? And this is, 15 years ago, I would have said you need to revascularize all of them, meaning either stents or bypass or something like that. We've learned something from a couple of studies over the last couple of years. So medical management is very important. So beta blockers to slow the heart rate down, less times that the blood's going to hit the wall. If I'm going fast, I have more chances to perpetuate the dissection. If I slow it down, less chances. Take some of the shear force off the vessel, and that should improve in terms of, it should improve the probability or decrease the probability of dissections extending. You have less ventricular tachycardia with beta blockers. Antiplatelet agents, so the old-fashioned aspirin, Plavix, whichever one you like. Their role is unknown, but we know that once that lumen starts, that vessel lumen starts to get squeezed and flow is impaired, as you have stasis of flow, slowing of flow, there's more clot. So theoretically, antiplatelet agents should prevent further closing of the vessel lumen.
So I have a question. When they're coming in and they have their chest pain, and usually we give them aspirin,
Yep.
right?
Yep.
But if they're truly dissecting, is that going to be a problem?
That's a great question. So the answer is we don't know for sure, but we do know that if we have compromise in a vessel lumen, that if we have aspirin, it's less likely that that platelet plug is going to finish it off and completely occlude it. So if I'm 99% occluded, that one little bit of flow will keep cells alive. You may have a lot of pain, you may lose some, but you won't lose all of them if you keep even a little bit of flow. So the general consensus is that yes, aspirin is reasonable therapy in these folks. But it's a very good question. Now, and I think I know what you may be kind of processing in that squash up there. But thrombolytics, which are very potent blood thinners, if you will, have been shown to worsen this problem. And so that's also been a concern when we used thrombolytics back in the day with an old-fashioned amount. Can we make that mural thrombus worse? And the answer is yes, you can. So it seems to be the right balance. A little's good of blood thinning, but too much might not be good. If that makes sense. And again, this is expert opinion. This is not written and granted by any means. This is what most people think is the best way to handle them right now. So, I mean, I guess it was what, 60% who got thrombolytics deteriorated after receiving a thrombolytic. So does that mean it's bad? Maybe they were going to get worse anyway, but it gives us all pause for thought with the very high-powered, going nuclear, if you will, with that powerful stuff. Now, how about revascularization? This is always contentious between those of us who do coronary interventions and the medical group. There are interesting data that are observational, and they show that many of these patients will heal within a month just by good medical therapy and observation. So some of them will heal. One of the questions that we always ask is that a group of patients that we selected as not needing to go to cath lab? And the answer is invariably always. When they're really unstable, they don't get it, the medical management watch and wait. So there are certainly a group of patients who is a smaller territory, who are doing pretty well, where we can watch and wait and probably should. We probably should have pushed on those patients. On the other hand, there's the group of patients who are clearly trying to die or dying in front of us, that waiting is not going to be the proper choice. But having said that, 73, 90, and 97% of cases have shown some degree of healing in 4 to 12 weeks. So there is data to say that there are groups of patients that can be safely watched, and that's probably the right answer for that group. On the other hand, there's a group like Our Lady that just had a baby, who is in shock and dying in front of our eyes. That watchful waiting is not going to work. We have to do whatever we can do. So hemodynamic instability, patients who we can't control medically, keep having the chest pain, leaking more enzymes. Those are the patients that we have to consider being more aggressive. And obviously the left main dissection, because that's a lethal problem. We can't really sit on that group either. There are a lot of challenges with coronary intervention. These are really super fragile arteries. I'm not kidding. You can touch them with a wire and you'll watch the dissection spin out. So you just have to pick very gentle equipment. Normally we say high pressure to make sure stent is fully expanded. In these patients, no high pressure. We don't want to extend the dissection. Gentle, just enough to get the stent against the wall and stop. And they're such soft arteries that you don't need to go high pressure. They're not like those old limestone arteries that in our 75 and 85-year-old patients. These are soft, and you can be very, very gentle and do just fine. It is true that some of these arteries will dissect all the way down to the bitter end, and now you have a really small vessel that we may not even have a small enough stent to stent. So the question in those patients is, where do we stop? Is sealing that entry point going to be good enough? And we don't always know. Sometimes it's best judgment. We do know that we need to use longer stents and make sure we try to get to healthy tissue, which is where some of those other imaging modalities can be very helpful. Long term, for you guys, one of the problems is you saw that OCT picture where there was the little hole which was where the blood was going through, but the artery was actually this big. So the trick is not to just get a stent that's halfway open the artery. We have to get the stent as big as the artery, because when this thing heals, if you don't have the stent against the wall, now you have this piece of metal in the middle of the artery, which is just an itis for another clot. So the trick is to be just perfect. You can't be too little, you can't be too big, you can't be too weak, you can't be too strong. You have to be just right.
Do you use drug-eluting stents or bare metal?
I do. I have, there's, again, my experience in these patients who have spontaneous coronary dissection, that they don't have a real big restenosis rate. That's been my own experience, but I just don't want to have that tissue's aggravated. We know that stenting does aggravate tissue and can promote excessive healing, so I'd like to have a along lines of we don't want to be going back on these patients. We just don't. Or I certainly don't. Don't want to have anybody come back. But these are particularly tricky. So I think the other eye-opener was this Mayo Clinic series. Now this is Mayo Clinic. They're not the best place on the planet, let me tell you. But and these were not all their patients, by the way. These are patients that were collected through their registry. So they're done in various hospitals that may have varying degrees of appreciation of what SCAD really is and how to treat it. But they found that there was about a 53% failure rate in angioplasty on a SCAD patient. We haven't had that. We haven't seen that, but we're extraordinarily careful. 13% of them went on to have to require surgery. In Vancouver, in Canada, Canada's a little different than the U.S. Everything kind of gets funneled from the provinces into the bigger centers. And they found that they had success or partial success in about 2/3 of the cases. That would never be an acceptable result in plain old-fashioned coronary disease. It's got to be 99 or next operator. But 60% had extension during their procedure, and that again is, I think, partly choosing the right equipment, being very careful, and being very patient. 12% of theirs needed an urgent CABG, and a little bit scary is that 6% of late stent thrombosis. So that's not getting the stent against the wall. That's going to be a cause of it most of the time.
So will they treat it with
Yeah, you should still be on, a stent should still be treated whether I'm doing it for coronary disease or spontaneous coronary dissection. You're still going to treat the same way with plaques, aspirin. No, they were treated, and so, I mean, that's a very good question, and what most people think is they didn't get that stent big enough. So, malapposition, undersizing the stent is a recipe for stent thrombosis. So, now, in SCAD patients, I don't, and it's been coronary disease patients, you want a big enough height. You want the stented segment to be bigger than the rest of the vessel. It should be against the wall. Does that make sense? So these are just kind of technical considerations. Again, you could presumably decrease the probability of stent thrombosis by using these intravascular tools to be sure your stent really is against the wall. Because on angiogram, you don't know how big that vessel is when there's all that stuff around it. Again, longer stents to make sure the whole dissection is covered. Now, I don't agree with doing OCT follow-up and redoing a procedure on these patients to make sure the stent's big enough, but some people have proposed it. And then this is the one that really drives me crazy. Use a cutting balloon to fenestrate so that the blood can get out of there. So a cutting balloon is just a balloon with razors, you know, 4 quadrants of it. That doesn't make sense to me, but people have proposed it. I disagree with it strongly. I think that makes no sense. Anyway, thank you very much for your attention. Go Cubs.
How do you treat aorta dissection?
So a lot of what we've talked about is similar. Now, aortic dissections depend on where in the aorta they are. So once you get into the aortic fluid, that's a surgical emergency. Every hour that goes by is another percent chance of the patient dying, literally. That first, we talk about golden windows of medicine, that's one of the true ones. So once the aorta gets by the great vessels and it's down, you know, in the abdomen or lower thorax, then is considered the preferred therapy. When they get complex, we can use endovascular graft devices to fix those. But endograft devices don't really work because you have all that up here. Once you get it where the great vessels are, you got to close them off. And penetrated devices take forever for that. So generally, when you're in the ascending aorta and in the arch, you're going to go to surgery. I hope you have a good surgeon who's got great endurance because it's taken a long time.
So, for example,
So no, I think that's a $1 million question. I would probably try a beta block because that is used in dissections and other settings. They have a friable tissue. I would tell them to pay attention to their symptoms. These folks learn when they're beginning to have trouble with it. They do figure it out, and maybe better than we do. I think you're right. I do believe in hydration. I think when you underhydrate and you start exercising, you're setting that up because those vessels are getting smaller. So I think you're absolutely right. I have one woman who was Thanksgiving or Christmas, and my goodness, I mean, she could outrun 99% of the planet. I remember telling her, "What the hell are you doing here?" She said, "No, I got something." And she had to pull it. So she's continued to jog. This is 15, 20 years ago. She's continued to jog religiously 3 miles, but she doesn't sprint. She jogs.
A heart rate, there's no heart rate limit, like,
Yeah.
weightlifting limit.
Weightlifting is probably not a good pursuit for those who have, pathology of their vessels. Because now, I don't want to get myself in trouble, but like lighter weights, multiple reps is probably okay. You're not. That you probably don't want to be doing. You don't want to be raising it up down on thoracic direction. Lighter weights where you're trying to just define muscle and get a little bit stronger is probably acceptable. But nobody knows for sure.
So the woman in our program who had SCAD, she was told not to do anything that was jerky motion, like don't run a roller coaster, and don't go horseback riding, things like that. That was a comment. But my question was, so when a 42-year-old woman comes into the ER and you're having chest pain, what's going to provoke you to do a
OCD.
So, or IRIS to rule out SCAD?
So the paradigm in my mind is this: troponin and EKG, old-fashioned stuff. If your troponin is abnormal, your 50 is abnormal, then you're not unlikely to go to the cath lab. And I think that's perfectly reasonable. Now, if they're negative, I think CT is a very, very interesting alternative. And I don't do CT. I'm saying, but I do think. I think Mayo Clinic is recommending for anybody that has known SCAD and has a change in symptom, start with, as long as your troponin and EKG are okay, start with a CT and see what's in jeopardy. How much tissue is in jeopardy. It's a little tiny distal vessel. Whoa, Nelly, put on the brakes. If it's a big vessel, then you may consider much more aggressive monitoring at the least, longer hospitalization, whatever. But not yet.
And then the last question is, if you're diagnosed with SCAD, does it put you at a higher risk for like thoracic or abdominal or carotid?
So probably fibromuscular dysplasia does. So I just saw a lady this week in clinic who's had a carotid stent from a spontaneous dissection, a vertebral dissection, and 2 coronaries. So the answer is if they're fibromuscular dysplasia, they're probably at risk for the other areas, which means beta block. So in terms of jerky movements, my best man, we were out playing basketball one day, and this was 25, 30 years ago, and he said, I think I got to stop. I got a headache and my right arm doesn't feel right. I said, I wonder if you got a complex migraine. So we stopped. He went in, he had a vertebral dissection. I'm sure it was when he was going up and he jerked his head up to shoot a leg. He's still fine now, but so they're out there. You just have to be aware. I think you educate them that if they have a similar symptom, they can get attention, and further educate them about how much attention. Because if not everybody, once you know you have SCAD, not everybody needs a cardiac catheterization. When you don't know what they have, they're probably out to get a cardiac cath. Does that make sense? So you educate them that, CT, NGR, if you go to a place where they have it, the one lady that said before was like, I went to the hospital and they told me my one was negative. I know something's there. And they said, well, there's nothing here. And she said, there is something. And she was right. She had a new dissection, which was picked up on CT. So they have to be persistent. Women are very hard to diagnose in the cardiovascular arena, and that's well known. Regular old heart disease is hard, but this is even harder. No more questions? Was that clear? Or you just want to see the
I have a
cups?
technical question in regards to the cath lab. So what's the difference between the IVUS and if you did like the IFR or the FFR? Is that just a percentage as compared to a picture?
So IVUS is a picture. IVUS is a picture going down the barrel of the gun, down the lumen area. FFR and IFR are really measuring flow. So they're going to tell you if flow is impaired or not with the FFR. The tradition is FFR or IFR is getting some popularity. So those are the differences. So ultrasound is going to tell you, is there a defect, is there a hematoma in the media? It may tell you if there's a rent or a defect in the wall, and it will tell you how big is the actual artery when it's fully expanded.
Did they ever do like an FFR and then follow with an IVUS?
Oh yeah,
Okay.
sure. For some of my partners do FFR, OCT, and IVUS on every patient. I think that's a lot. I think
Awesome.
it does, and there's also chances. Every time you introduce some, there's one more chance for a problem. So I tend to be relatively straightforward, but there are times when those tools are absolutely, you just need to know when that is.
So is the FFR measuring the velocity of the flow not releasing?
So you're basically, it's actually a pressure measurement. So it's fractional flow reserve, but basically you've got a crystal that measures pressure beyond the blockages, and then you have your guiding catheter that's measuring pressure in the aorta, and that's a relative pressure difference. So it's fractional flow reserve, but it's actually pressure rates. It's basically what we did 30 years ago when we used to take the wire out of the balloon to measure the pressure. This has been valid, but the thing about FFR was it was validated. That if your FFR is adequate, you don't need to do anything, and those patients will do okay for them if not wrong. Versus if the FFR is impaired, if the FFR is abnormal, below a certain number, you know they're likely to come back and have a higher probability of being hospitalized. It's a relative number. I think we usually apply it to big ones and small ones. That's it. Okay.
Thank you so much, Dr. Lewis. So helpful. I don't want you to forget your PowerPoint here.
I thought I got it.
Oh no, this
That's
is
yours.
Dayna who's going to talk next. So I just want to remind you that we're videotaping this. So if you need to go back and review, if you need to be able to see his PowerPoint better, it will be on the ISCHR website. So speaking of ISCHR, they're sponsoring this event through the CEUs and the speaker. Those of you who are ISCHR members, we really encourage you to check that out. It's a great organization. I've been in ISCHR starting more than 30 years ago, and it has always provided me with information on reimbursement, on the latest policies and procedures, on networking among our fellow professionals. Great information, great guiding source, and also to constantly Dayna went through this, so she's going to give more of a personal view of what you might see from our patients. Welcome, Dayna. Oh, sorry. Did not take the bar out. Got it?
Thank you, Mary. Just to repeat, my name is Dayna Mitchell, here speaking as a patient, which is a little different for me. I'm actually a pharmacist at Hines VA Hospital across the street from Loyola's main campus. So I'm used to speaking as a pharmacist and not as a patient. So it's a little weird to prepare my slides as a patient. So I was thinking about what I wanted to talk about briefly with you tonight. So I thought of 3 things that I thought might be helpful. Hopefully by tonight you'll be able to review at least one patient's personal experience with SCAD, to describe some of the unique challenges for patients who've had a SCAD event, and to give you some resources post-event for patients. So as Dr. Lewis mentioned, more than half of patients have some sort of inciting event, either emotional or physical. I had neither of those. 3 days before my event, this is where I was in Mexico. You can see the sign there, La Buena Vida, at the restaurant, The Good Life. And the night I had my SCAD, I was actually eating takeout noodles and company and watching HGTV. So none of that is stressful at all. I was having a pretty chill time. So as far as my experience though, I had significant symptoms, and I was one of those people who had 0 history. No issues with hypertension, diabetes, smoking, family history, great lipid profile, you name it. I had absolutely no reason to have a SCAD event. But what happened was I was home alone, I was eating, and I thought, oh, I have like an esophageal spasm, something strange going on. Didn't really get better, and then I started getting cramps like in my neck and my shoulders. And I thought, what the heck is going on? I hadn't been to yoga, I hadn't been to the gym because I'd just been in Mexico. Put a heating pad on, got better, 5, 10, 15 minutes later. Okay, start eating again, and it happens again. I thought, what the heck is going on? So I did what I always do when you don't feel well, you take a hot bath. And just as I'm getting ready to step in the bathtub, I think to myself, you know, if you're having some sort of major medical problem, and the EMTs have to come, if they have to pull you out of the tub, you're going to be wet and naked. So maybe skip the bath. So I didn't get in the bath, and literally 2 minutes later, I thought, I have to go to the emergency department. Something is really wrong. I don't know what, something's really wrong. And for someone who works in healthcare at the VA, where we have elderly men who have heart attacks literally every day, I still couldn't put it together that that's what was happening to me, because it didn't make any sense. My symptoms did get better after an hour and a half, so as I went to the ED, I knew the magic words to say, I have chest pain, I'm short of breath, I can't feel my arms, so they took me right back. I'm sorry. I did not drive myself. I did what all women do when they're in trouble. I called my mom. She lives about 10 minutes away. She answered the phone. In retrospect, I should have called 911. But so my mom did actually drive me to the emergency department. I don't recommend that. So in the ED, I'll go ahead and move forward here. My slides don't like your version of PowerPoint at all. Oh dear, okay. Let me just move forward here. Sorry, so it really wasn't working. Basically, my troponins came back in the ED at about 1. which is elevated, but I still wasn't buying it, and I was actually feeling much better by the time the lab came back. And the nurses said, we're giving you IV heparin, so the nomogram, we're giving you aspirin, and we're admitting you to the ICU. What? So I was feeling much better at that point. I actually was helping the nurses calculate my heparin dose for the nomogram. I'm a pharmacist, what can I say? So the next morning, or actually overnight, my next set of troponins came back at 9. And it was at that point I'm like, yeah, I'm gonna need a cath. What is going on? So the next morning I took him for a cath, and when I woke up, I had 36 millimeters of stent in my LAD. So stayed in the hospital another day or two, just trying to get my head around what happened and how my life was gonna be different now. I was discharged, and about 24 hours later, I was having some mild chest pain, which before all this happened, I would have said, oh, it's a little heartburn, take a Tums, move on. And after about an hour and a half, I was like really scared. So I went back to the ED thinking, oh, they'll just recheck my troponins, check an EKG, and I'll get to go home. Foolish me, they're like, no, you're getting admitted again. So they really wanted me to have another cath, which I really did not want to have because they're unpleasant. And it still really didn't make much sense what was happening. Eventually they talked me into having another cath, and I got another 14 millimeters of stent. Same vessel, distal to the original 2 stents that were placed. So, and then a day or two after that, I was discharged a second time. So this is actually a picture of the sunrise or the sunset from one of my nights in the hospital. Saving grace there. And then, about 4 weeks after my last stent, I started cardiac rehab with Mary and Liz, and this is my second to the last day in rehab. One of the things the doctors did do, all of the doctors that I saw, they all really recommended that I have cardiac rehab. And I don't think all patients get that message. So I think that was really helpful for me. And although a lot of the patients in rehab didn't really look like me or have a lot of the same issues I was having, it was still really helpful. And they all said it's not only for your physical well-being, it's for your mental well-being. And I think that's really true, because when you've been very healthy and active and you're just hit in the face with this, you're scared, like, can I go upstairs? Can I carry the laundry? Can I ride a bike? Can I go back to Zumba class and yoga class and all the other things I did 10 seconds before all this happened? And you can get your confidence back. I think that's really helpful. And at least the cardiac nurses I had were terrific. They were very kind. Just were really helpful, and appreciated their patience with me as I would try to do something, and they would be like, Dayna, your heart rate's a little high, take it down. I'm like, but I made it to 4 miles an hour, come on. And they're so when I would get frustrated, they would be patient with me, and were very kind. There actually was another SCAD patient in my rehab with me, so that was kind of nice. We could share stories. Unfortunately, she actually had a second event in the middle of her rehab and had to have another cardiac cath. So that was really depressing for her and for me, because you know it can happen again at any time. I will say for cardiac rehab for young women, not only for myself but other patients I know, it can be really challenging to schedule when you're trying to work and do daycare and take care of your kids and run your kids to wherever they need to go. A lot of people really struggle with that, so scheduling can be really hard for people. A lot of people really want to do it, and literally they just can't get it their schedule. Or sadly, I learned that a lot of times patients can't get it paid for either, depending on their various insurance. Doesn't like that either. So challenges, sorry for the ugly slide here. Challenges for SCAD patients, really in shock and surprise and not really sure where to turn because we don't fit the typical mold. And there's not a lot we can do to prevent it in the future. I told my family if I was like a smoking, overweight diabetic, I'm like, hey, look at all these things I could do. I'm like, what can I do? there's not as many choices as there are for other patients. Being misdiagnosed, or if you prefer undiagnosed, actually the doctors who cared for me for both of my admissions did not know I had SCAD. They actually treated me with atherosclerosis. So they just treated me like a standard patient. The only reason that I know I have SCAD or had a SCAD event is because a friend of a friend is a cardiologist at Loyola, one of Dr. Lewis's colleagues, who heard my story and went, wait a minute, I wonder if you had a dissection. And I'm like, what are you talking about? I got my cath films, and out of courtesy, her and Dr. Matthew at Loyola read them and said, yeah, we think you have SCAD. We don't think you have atherosclerosis. You have all of the signals that it's a SCAD, not atherosclerosis. So the only reason I know I have a SCAD is because I have a girlfriend who has a girlfriend who's a cardiologist at Loyola. So I think there's a lot of us out there that are probably undiagnosed still to this day. It is scary. Some of the other challenges for SCAD patients, if you end up on dual antiplatelet therapy, a lot of MI patients are not menstruating either because they're men or because they're postmenopausal. These are the kinds of things that a lot of people don't know how to handle. The American Heart Association published the SCAD consensus statement in February. They do an excellent job discussing all kinds of issues for these kinds of patients and how do you manage this? What if people want to go on to have more children? When generally people who've had a SCAD event are recommended not to have more children. That's devastating to a woman who's, 27 years old and hasn't had a child yet, or has only had one and wants to grow her family. So there's a lot of issues, I think, that don't often pertain to other MI patients. And then the last thing I was going to talk about for challenges for SCAD patients is a lot of us have ongoing symptoms or chest pain, chest discomfort, whatever you want to call it. And Dr. Lewis talked about that these patients can often kind of figure out like what's really a symptom I need to worry about and go to the emergency department versus not. It's really hard as a patient to know that. As my cardiac rehab nurses know, I had this sort of lingering, ongoing, mild chest pain for months after my event. Now, it could have been from my stents, the actual physical presence of the stent. Could it be vasospasm? Could it be microvascular disease? Often we don't really know. Some of these patients have ongoing pain for months, years. Some can be treated with various medications. Some really don't have good luck. I feel pretty lucky. I still have a little daily pain on and off, but I've learned it's not something I need to go to the emergency department for. It would have to be more severe, more constant before I would go to the emergency department. So that's a really hard thing for patients. Interestingly for me, getting on the treadmill at cardiac rehab didn't make it better, didn't make it worse. It was kind of the same. That kind of led me personally to believe it's probably not cardiac, or if it is, it's not something that exercise is going to make worse. So I learned that even with this kind of funky chest discomfort, whatever you want to call it, I was as safe as I could be to exercise. A lot of SCAD patients end up having to educate themselves because a lot of doctors are not terribly knowledgeable about the newest evidence. The American Heart Association consensus statement is really helpful. So I always recommend that patients, if your doctor's not familiar with it, get a copy in their hands because it'll be valuable for them. It's actually, I think, pretty valuable for patients to read. It was for me, but I'm also a healthcare professional. So if patients have people they know who are healthcare professionals that can help walk them through it, it answers a ton of questions. And I just thought it was extremely valuable that was published. And something that was just published in September, Early Natural History of Spontaneous Coronary Artery Dissection, is kind of giving us some more clues about what is the natural progression, how likely are you to have another event, at least in the short term. Is there a way we can predict who will do better or worse? There's beginning clues of what we can learn from that. Oh man. Okay, so this slide of resources, which is not good here, I'm going to just go to the next slide. I'll talk about 3 resources for patients I wanted to tell you about. One is an organization called SCAD Research, which was started by a widower whose wife died of SCAD when she was, I think Judy was 42. This lovely man named Bob, he started a fundraising organization because there was so little research, and the only way there was going to be research would be if patients got together, started raising money to pay someone to do the research, because it's pretty uncommon. No one else is going to pay for it. So they have their own webpage called SCAD Research. There's also an organization called SCAD Alliance, which is both clinicians, patients, and their families. Again, fundraising and awareness. They've got a really nice webpage. And they actually just sponsored a group that published something recently in one of the cardiac rehab journals, which is on my slide, which we can't read, like in the last year, about the psychosocial impact on a group of female patients who've had a SCAD event. So I think maybe for this audience, that might be really helpful for you guys to take a look at. Hopefully we can get my slides fixed. And then lastly, there is a ton of us on Facebook. Surprise. There's multiple SCAD organizations on Facebook, several just for survivors. Still having a little trouble with that word. The largest one is called SCAD Survivors. There's 2,800 people on it that are survivors alone. You can only join a group if you've actually had a SCAD event. It's a very helpful place to get support from other people who've gone through the experience. There's a lot of posting. I would say 5 times a day there's people posting, hey, I have this chest pain again, what do I do? You know, it's not really meant to give medical advice, but really a lot of times these patients, especially if they live in rural areas, if they don't have a doctor who has experience with SCAD, they really don't have a lot of good places to turn. So I think those are helpful. I will say that those Facebook groups can be overwhelming. There's a lot of very sick patients on the group, people who got heart transplants, people who had multiple cabbages, people who had 6 events in the last 6 months. And then there's people who's like, well, I didn't have an event for 15 years. I'm just now having my 2nd event 15 years later. Like, okay, well, you made it 15 years. So it can be a little overwhelming, but there's a lot of support there too. I have to do it in small doses, otherwise it kind of takes over your life. I talked a little bit about SCAD research and the fundraising. So one of the biggest ways we do fundraising is we do 5Ks, as fundraisers, which we call skedaddles. So this is the one that was in Chicago. I was able to walk it June 2nd. My SCAD event was March 27th, so just a couple months later, I was able to do it. So there's a couple of us here that are in the photo. I think Bob might be in there somewhere too, in honor of his wife. So here's me and my daughter. My daughter actually placed in her age group for the race, so that was nice. I just thought that this was funny. You can see, this is actually the SCAD Survivors group. Someone said, I started working out again. And they put the little, does refusing to do cardio count as resistance training? People often post inspirational things, funny things. Sometimes people just need to vent because they're not getting good care wherever they're going. So that's just something fun. So I'd be happy to take any questions.
Did your doctor give you any specific guidelines about your heart rate not going above a certain rate or your blood pressure not going above a certain?
So did my doctor give me any guidance as far as max heart rate or max blood pressure? The answer is no. So I did, in cardiac rehab, I think I was at about, maybe 85% was my max, so I tried to stay below that. I'm still trying to stay below that, but there's really not, I wasn't really given any good guidance. One of the nice things about the 5Ks is they often try and have some of the national experts come and speak to the patients with the newest research in SCAD. When I went to the one in June, Sharon Hayes, who's the lead author of the American Heart Association consensus statement, she gave a really nice talk. And she didn't give hard guidelines, but she did say, as far as like lifting things, As was mentioned here before, you know, anything that's going to cause you to really strain, hold your breath, if you have to do that to lift, she would generally avoid that for most patients. She said, like, her example, I think, was like, if you have to lift a 40-pound bag of salt to put in your water softener, she's like, for me, that might be really hard, so I couldn't do that. Somebody else might be able to do that easily without having to hold their breath and strain, so it kind of depends on the person. But it was more about the straining and holding your breath. The guidelines do talk about, you know, not endurance sort of things, so generally not marathons, usually not doing things in extreme weather conditions, so hot yoga or swimming in an icy cold lake, because there have been events that have happened after those sorts of activities. Is it hereditary? So what I have read from the American Heart Association consensus statement, there's a small number of patients where they have found a family connection, like there's mother-daughter or sisters. Generally not thought to be genetic, but there's ongoing research in the area. I know Mayo Clinic is doing research. Part of it is that they have a whole bunch of blood samples they'd like to test, but they don't have funding to run it. So thus all of us are doing skedaddles to try to keep raising money. At the Mayo Clinic, their registry now is, I think, about 1,000 patients they have registered. I know I sent my cath films in, I think I sent them in July. I still haven't heard back because they have a big backlog, because again, it's all volunteer and they're waiting for more funding. So I actually am going to Mayo Clinic next Tuesday for CT, brain, neck, abdomen, pelvis to look for fibromuscular dysplasia that Dr. Lewis talked about, and then I'll have a little bit better idea where I am with future risk, kind of, sort of, as much as we'll know.
Are you still on the beta blocker?
I'm still on beta blocker. I'm only on metoprolol SA 25 once a day. I tolerate that just fine. I don't really think I have much for side effects from it. A lot of patients, as women, really have trouble with weight gain, dizziness, not generally feeling well on the beta blocker, so a lot of people do struggle with that. I don't know how long I'll end up staying on it. I mean, my baseline blood pressure before all of this was like 100/65. That was like my baseline, so I can't really do a whole lot more. But it seems to do a pretty good job with my my heart rate.
Talk about how this has affected your family.
How this has affected my family. So my husband is super freaked out, quite honestly. He actually has a very bad family history of heart disease in his family. His father actually died of a massive MI. I think he was 53 or 54, and my husband was like the one who found his father, like on the sidewalk. He's got terrible cholesterol, just a bad family history. So we always were prepared, like what happens if it happens to him. So he's still really kind of processing this, maybe even more than I am. My children, who are 19 and 15, we told them bits and pieces, but whenever they saw me, I looked pretty well. I had a non-STEMI, and I recovered relatively quickly. So for them, they're like, oh yeah, mom had that heart thing, and she's fine, she's still doing laundry, and still going to yoga class, and still going to Zumba, and runs around the house. And so I think for them, I don't think they really fully grasped the severity of it. I know a lot of other people's family just from Facebook, the kids really struggle and are very concerned. I think the other problem people have is because when you do recover, and because as women, I think as parents, we're sometimes the one kind of coordinating everything and being in charge, and people are like, oh look, you're fine, you can still do everything you used to be, why are you so upset? And people are like, no really, I had a major event in my life. People call the anniversary of their SCAD event their SCADiversary in the lingo. So people are like, hey, I had my 1-year SCADiversary and nobody even noticed. And some people get really upset. It's like, does my family not remember this huge trauma I went through? And if I bring it up, my family says, oh, you're fine now. You're all fixed, you're fine. That hasn't been my experience, but there are a lot of people out there that have that experience. experience. And so that's where sometimes the Facebook group is really helpful, because other people will say, well, I care, I know what you're thinking, I know what you're feeling. Not everybody feels, super supportive. So.
Two questions. One is, what is the most therapeutic thing or event that someone did for you in your recovery that really helped make a difference? We as healthcare professionals, as yourselves, have realized oftentimes we don't know what to say or do, but if there's something that really truly made a difference, in addition to Liz and who was the other person, I'm sorry.
Mary.
Liz and Mary, that was here on rehab. And then also, how has your life, if it has changed, your perspective, as far as epiphany moments, or has it given you any broader vision, raising your children, and anything of that nature?
I would say first, I had a really good friend at work who's also a pharmacist, and she happens to be the one who called her friend the cardiologist. And because she's a healthcare worker and she's my very good friend, I was able to text her kind of like anytime and just vent about various things, and she just kind of let me complain or help me think about different questions. So I think having an ear who can listen is really helpful, and sort of not be judgmental about what you're thinking or feeling as a patient. I work at the VA, so I see very sick, sad stories all the time. We have a blind rehab center there. I see blind patients training all the time. We have spinal cord injury. I see permanently disabled patients using wheelchairs every day. So you would think that would make you say, well, see, what you had isn't so bad. But sometimes you just want to tell somebody, it was really bad and really hard, and I'd like a little sympathy. So having that ear for somebody, whether that be a healthcare professional or someone else, just to acknowledge that, and that you're going to have good days and you're going to have bad days, for me, is really helpful. As far as an epiphany moment, not really, but I have had to make some life changes to make me a lot more prepared. I wear my medical ID bracelet, so that should I fall down today and I'm not here with a whole group of cardiology specialists, someone will know I have stents and I had a dissection, so please don't give me more stents if I don't need them. I actually don't know if I should have had the stents placed or not. That'll be a question for Mayo Clinic. Maybe I would have done better without. They're in there now, so they're in there forever. So we'll be living with that and the meds associated with those. I'm a little bit more consistent with my cardio exercise now. I was always pretty good, but I'm a little more diligent about that now. And my husband's really good about going to the gym with me or saying, yes, I'll do the dishes so you can go to Zumba class or whatever. I'm very adherent with my medications. Being a pharmacist, I know what happens to your stents if you don't take your drugs. It's not pretty, so I will be avoiding instant thrombosis as much as possible by taking my meds. Like, I have my phone set to take my meds every day at 8:30 a.m. and p.m. So my alarm goes off and my husband goes, oh, drug time. I'm like, yep, drug time. So that's a bit of an adjustment, mostly because I never took medication before, and I'm reminded every 12 hours that I had this event, and I have these stents that I'll have forever, that I might have an event again every 12 hours. I'm always reminded of that. It never goes away. So most of the time I'm like, yeah, stupid drugs, I'm gonna move on, but it's a different, it's different when you're not used to having a chronic illness or a chronic problem.
So, thinking back, before that night when you were reading your notes, did you have any, do you think you ever had any previous symptoms?
I don't think I ever had any symptoms. No.
It's always an acute event like that?
There are, I can just tell you from Facebook accounts, from all of the people who post, there are people who are like, I felt really tired for 2 weeks and I knew something wasn't right, and then I had this like a slow onset chest pain. So there are stories where it's not like, boom, you're having an acute event. There are other stories that are like less dramatic and more slow onset. I don't have any idea what the percentage of that is as far as presentation. Some of us had very dramatic onset as I look at some other people in the audience.